Hello, I'm Dr. Daniel Griffin.
And I'm Dixon Dupommier.
And today we will be discussing diarrhea and dehydration.
Yep.
Okay.
Two related problems.
Very much related. We have our water here in case we start getting dehydrated.
Well, there are symbols for what we're going to get at here, I'm sure.
Well, diarrhea, I think everyone probably in the audience has either had it themselves or known someone who's had it or had it themselves.
You bet.
This is very common.
Yeah.
Not only is it a very common complaint throughout the world, but it actually continues to be a major cause of death. That's right. It is certainly a major cause of inconvenience, misery, and suffering throughout the world.
Exactly.
We've made some major strides, which we're going to be talking about. But the big thing, I think there's two things I really want to push forward, and we're going to talk more and more about this. One is that most diarrhea does not require antibiotics.
Right.
And the second is we're going to be dividing diarrhea into non-bloody and bloody diarrhea, and that's going to help guide us in our discussion.
Right.
So, Dixon, I don't know if it's appropriate to ask or not, but you've had some diarrhea maybe in your life?
I've had a few loose stools in my time.
Loose stools?
I've eaten in a few places that I've regretted later, or had a few meals that I've prepared myself that sat out a little bit too long, and the next day, of course, or the day after that, you get hungry and you eat them. And there are things dwelling in these that will give you diarrhea. There's no question about it.
And the diarrhea you had, we make this distinction in acute and chronic. Were this short-lived episodes, or did this go on for a lengthy period of time?
I don't recall having any diarrheal disease per se. I can recall having diarrhea, but I cannot recall having a disease that was induced by that condition that lasted for more than 2 or 3 days.
Yeah, and I think that is typical. Most diarrhea is self-limited.
Yep.
And by self-limited means we do nothing as long as we stay adequately hydrated, which is not
and don't eat that again.
Which is not do nothing. That usually it lasts, as you describe, a short period of time, maybe 3 days at the most, and then it's something that we
That's right.
get rid of. And
now,
yes,
I said it was something I ate. There are two things to distinguish from each other. One is food poisoning, which is not diarrheal disease. Although it could lead to diarrhea, it's usually an immediate response. Food poisoning is something that you can get within 3 to 5 hours after you ingest something because there's a toxin involved. It really makes you feel bad.
No,
Confirm?
I think that's a good point.
And then there's the disease that follows that from something that either gained a foothold in your small intestine or large intestine and started to induce this loose, watery stool condition that we're going to call diarrhea.
Yeah, we try to break these talks down in like introduction with an overview, and then we talk about clinical disease and diagnosis. But the clinical disease and diagnosis really are connected a lot here, and I think you're starting to bring that up.
So a case history is necessary.
Yeah, so people always come in and like you say, that is classic. Like, I ate such and such, and this is why I got sick.
That's right.
And with our toxin-mediated, our call it food poisoning, the classic food poisoning.
Yeah.
Like, let's say staph, something that produces a toxin, has gotten on the mayonnaise or the food, and it's sat around, and the hygiene was an issue. And then we eat it, and a matter of hours later, maybe we're vomiting.
Yeah.
If there is a diarrhea, it tends to be very short-limited.
That's correct. It's pretty acute.
And antibiotics play no role because the bacteria, it's actually not in you. The bacteria is out there on the food, like growing some more toxin for the next person to come along.
So if you see that at one of these rural clinics, what is your first question?
So the interesting issue is, how do we identify that it's that, right? And so the history is going to be, because they're always going to tell you, they always identify, people often identify, the immediate meal before, and what we often say, I went and I had this meal, we say it's not that meal. What did you eat the day before? And so that's always the challenge. Is it just this preformed toxin that's giving an issue, or is it something you ingested a couple days or as much as 2 weeks before? So it's often hard to identify the culprits.
I was hoping you would also say, and I know you would have if I had prompted you, to say, and is anybody else in your family ill with the same disease?
Well, that's an interesting one, and we try. Not only do we want to know are other people sick, but it's always great to know are there non-family members. So we want to know. Let's say there was 20. There were 20 people that ate at this one
picnic or whatever.
This one
celebration.
Picnics are great.
Yeah, they're
outdoor where people brought food.
That's right.
They had been
That's
sitting,
right.
or went to a certain eating establishment, a restaurant, or a cafe, or what be it. And then not only do you and your 3, family members get sick. There was an outbreak I recently got a call about where there was a gathering, and there were 80 people at this gathering. 80 people. And not only did 40 of the people at the gathering get sick, an average of about 48 hours later, but there were some people who were at the gathering who didn't even eat who got sick.
Right.
And so that's an interesting. Initially, people are like, "What food could it be? Did everyone eat the chicken? Did everyone eat?" In this case, it actually was a norovirus. It was a viral outbreak, and so the reason we identified eventually we actually identified it with testing, but the hints were the fact that it was the person who was shaking everyone's hands, the not eating the food, who got sick, a maitre d' type person, and then the couple other people who were actually on another level of this, they got sick too, but it was also. So a lot of times there's a lot of detective work here, which is exciting on the diagnostic
I love this
sides.
topic for that reason. I really do.
And so in this case, it was a watery diarrhea. It was a viral mediated. It was no question of antibiotics. It was a question of keeping people well hydrated as they went through their self-limited diarrheal phase. And as we're talking about, so we've talked a little bit right here about the self-limited, but what about the diarrhea that's a little more involved? What about the bloody diarrhea, the diarrhea with fever, the diarrhea where the person is really, really ill?
Or the dysentery. I mean, I guess bloody diarrhea would be classified as dysentery.
So that's an interesting, so that, there are these like strict definitions on like, what defines diarrhea, what defines dysentery, and I tend to use the term bloody versus non-bloody diarrhea.
Got it.
And I also am a little bit looser with the definition of, the strict definition is like more than 3 stools.
And what is the biggest fear of someone going to the tropics for the first time as a newly minted physician to an area, let's say, on a coastal region of the tropics?
What is your biggest fear, Dixon?
I can tell you right now it would be cholera. So I think cholera is the gold standard for diarrheal disease. At least in the past it was. And I've actually had the privilege of visiting the International Cholera Center in Bangladesh and seeing the cholera cots that they use to treat patients for cholera. And you think of cholera as a long-term protracted diarrheal disease. It's not. It lasts for about 3 to 5 days, and that's it. And the miracle is, of course, I'm stepping on your territory here, but I think
that's
the
fine.
miracle is that if you have a little container filled with saline solution and your baby is suffering from cholera, all day long for 3 days, you're spoon feeding this fluid into this child, and 3 days later they get better. So this has a biological explanation, of course, and it's unlike any other diarrheal disease.
So let's break down, because we're going to do a whole separate talk on cholera. People may have already listened to that one. I don't know.
I don't either.
But
I hope I will.
But so we will. So we have our watery diarrhea. We have our bloody diarrhea. But cholera diarrhea is kind of a little bit different. It's totally in the watery diarrhea, but it is a lot. We describe it as a rice water diarrhea.
Rice water, but that's in quotes, isn't it? It isn't really rice, is it?
And the thing is the amount of volume, and that's why they have these special cuts. You may produce a liter or a quart, depending on what unit you want, per hour. I mean, it is pouring out. So I like your idea of giving the baby the spoons of rehydration. The amount of rehydration is huge. That's going to be required. We're going to talk about that.
But why does it only take 3 days to? I was stuck on this one for a long time.
Why is it only 3 days?
Yeah, until I heard the true explanation of what's going on, and then it's easy to understand because the rice in rice water diarrhea and cholera are actually the cells lining the surface of the villus of your small intestine, and it sloughs off, and it takes about 3 more days for the cells in the crypt of the villus to grow back enough to prevent the secretory diarrhea caused by the toxin that the cholera organism produces. And so it's a 3-day period. If you exceed the 3 days, you're good.
Yeah, if you make it through your 3 days, you're in good shape.
That's
so
right.
we've got our watery diarrhea, we've got our cholera diarrhea. These are nice to keep together because these are going to be treated purely with rehydration. So
Exactly.
everyone's going to get rehydration.
Exactly.
A minority of people are going to get antibiotics. So let's talk about oral rehydration. What is oral rehydration? Is it a glass of water like that?
It's not a glass of distilled water. No, it is not. Or even filtered water. It's not a glass of pure drinking water. It is as they call it, a pot full of water and a handful of salt. A pot full of water and a handful of salt.
And it's actually gotten a little more complicated. And actually, this is amazing.
Please.
This technology, I'll say. What we talk about technology and the introduction of oral rehydration salts. These packets that have glucose in there. They have salt in there. They have potassium in there.
Right.
Sometimes there's a bicarbonate, so there's something to help with the losses that way. The introduction of these oral rehydration solutions that are usually reconstituted from these packets has reduced the mortality from diarrhea. It used to be 20,000 children per day died of dehydration, and now the majority of those are saved by just simply rehydrating them with the right electrolyte solution.
So I was really distressed to learn of the cholera outbreak that occurred in Haiti some time ago as a result of the earthquake and then the disaster that followed. There were lots of deaths that resulted from that outbreak of cholera that was brought to Haiti from another place. Where was the medical help? Haiti is an island that's not very far away from the mainland of the United States. Why were we there with all of our resources? There should have been no deaths.
You know, it is tough. There's
Isn't that what Parasites Without Borders is all about?
We'll talk more about cholera later, but there's unfortunately the oral rehydration will not give you a 100% cure rate in cholera because there's a variant, about 10% of the time, a vomiting variant. And I don't know if you ever read the book, The Painted Veil.
I have not.
By Somerset Maugham.
No, but perhaps I will now.
But it's a wonderful book. I recommend that if people want to read a book. But unfortunately, sometimes we talk about real oral rehydration, but cholera is a great example you bring up. The vomiting prevents us from being able to actually orally rehydrate. And in those situations, you're going to need IV fluids.
Wow.
So in our diarrhea dehydration, as much as we talk about oral rehydration, there will be incidents where the vomiting prevents the success. And we actually need to use intravenous fluids. And there's a bunch of different ways of assessing the hydration status to do that. But I will say the vast majority of the time, 90% of the time, the oral rehydration is going to get us where we need to be. We may introduce intravenous if we need to. And in certain cases, we're going to introduce zinc supplements and antibiotics.
That's interesting. Now, where does that come from?
So those were some studies done in children in sub-Saharan Africa showing that if you give zinc supplementation for 5 days, you actually reduce not only the duration of the diarrhea, the severity of the diarrhea, but you may actually prevent deaths.
Do we know what the mechanism is?
Not completely. Not completely. We think it has something to do with the immune function, and people are looking at this. Also the issue of do we restrict it just to children in these areas, or do we give everyone zinc supplements when they're having diarrhea? These are still sort of...
So there's another diarrheal disease I'm sure you're familiar with because we teach this together. It's induced by an organism in this case. And the fluid that is the result of the infection, which is from Cryptosporidium, is a watery diarrhea. And if you have HIV thrown on top of that, then you can produce as much stool as you can with a cholera outbreak.
Yes.
Now you have to tell the difference between an AIDS patient suffering from Cryptosporidium with a patient suffering from cholera. And the rice portion of the cholera, I presume, would be the dead giveaway. But there's still some distinctions to be made about secretory versus non-secretory diarrhea.
Well, and I think as we learned, there was a really large study called the GEM study, and it was looking at diarrhea in a lot of different parts of the world. And it changed in a lot of ways our knowledge about what pathogens to worry about. So let's talk about some of the pathogens we may be using antibiotics.
Go for
And in our guide, we talk a little bit about bloody diarrhea, and the acute onset of bloody diarrhea, the most common would be actually Shigella. Interesting.
Oh, Shigella,
Yeah.
okay.
I always, people often, worry about typhoid, and I think that's reasonable.
I whispered it, by the way.
Yeah,
I didn't
you whispered it. I'm thinking you might have been worried about that. We talk here in our book about the
Is that Shigella
so people can
flexneri
see
by
that.
any chance?
It can be. That would be.
I spent some time in Flexner Hall. That's the only
We
reason I'm
also,
interested in that.
Campylobacter sometimes can give us a bloody diarrhea. Sometimes our variants of E. coli can give us bloody diarrhea. This is usually our, acute onset. Exposure, it lasts, and it usually is pretty severe, usually accompanied with fever. And in those cases, and we actually talk about in our treatment, not only will we recommend the rehydration to everybody,
Right.
but actually we'll start getting to the point where we consider azithromycin as one of the treatments of choice. And part of that, over Cipro, which in many areas is a second-line medication, is resistance rates. As we use too many of these antibiotics, we start seeing resistance.
That's ciprofloxacin, by the way, for the...
I'm glad you jump in with that. And
I've been taking it.
versus the azithromycin.
That's right.
But the other, which we don't want to leave out, is let's say the diarrhea took a while and it's been going on for a more long period of time, and this is where we get into our parasites, right?
I'm going to go right with it.
And so let's
Going
say it's a bloody diarrhea. The person's been away from potential for 2 weeks, and now it's kind of going along, lingering, but it's bloody. What would
Now it's getting worse. Well, I mean, my first thought would be Entamoeba histolytica,
and
but
I think that is classic. And a lot of times, if we're in an area where we can't make the distinction because we lack the diagnostic testing, we may give them a dose of azithromycin, or we may even do the 3-day of azithromycin and the metronidazole.
Right.
And then the cyst stage, we might use a peromamycin or an itaquinol.
Iodoquinol, sure.
Yeah, things to. But now, what if they've been in this area and they're having the diarrhea? It's not bloody, but it's greasy, it's foul smelling, it's been going on for a while.
And they've just come back from a camping trip.
Or they're living in the tropics.
Or they're living in the tropics. Well, that would be Giardia.
And so then we start thinking about Giardia. So it can get a little bit more. We can get a little subtleties.
Absolutely.
But, as a recap.
And if you live in Cochin, China.
Yes, could have Cochin, China diarrhea.
That's right, from strongyloides. So we have a lot of choices.
We do have a lot of choices. But the majority of the time, I'm going to say, is 90% of the time we're getting our watery diarrhea. It's going to be viral or one of these self-limited infections.
Rotavirus.
Oral rehydration is going to be our mainstay of therapy.
Yep.
Maybe with our zinc supplements, which we talked about.
Yep.
Sometimes we're going to have bloody diarrhea where we start thinking about something such as one of our antibiotics. It might be more of our chronic parasitics where we worry about amoeba and Giardia and those treatments.
Or trichuris. Don't forget trichuris.
Mm-hmm.
That can give you a diarrheal disease. It can be protracted.
True.
So, I mean, that worm lives for 3 years, so it has plenty of time to induce diarrhea.
Yeah. Don't forget our soil transmitted and other helminths.
Exactly right. And we have a good drug that takes care of most of them. So I think in that case, especially with a pediatric population, you've got several interesting choices for diarrheal disease.
And don't forget, if someone is sick enough that they're not going to do the oral rehydration, then we need to think about our intravenous.
That's right. And that might be a challenge in some areas.
In a lot of areas. That is not something you can easily access.
The other thing, as a doc, you know this too, and I've been told this many times by other people, if you're suffering from acute dehydration due to diarrheal disease, finding the vein to insert the needle is a big challenge.
Particularly in a young child.
Because all of the tissues are shrunk and the vein doesn't stand out, and it's hard to find it. And you're searching and searching and searching, and it's just,
so in a lot of our lectures, we talk about this, that if someone is ill to the point where it's beyond your clinic's capacity, you need to know what are the other resources you can get involved.
Exactly.
You may need to send this individual to a higher level of care.
Yep.
Where maybe the intravenous is a central line. It may be intraosseous. They may actually put a line directly into the bone and then infuse that way.
Wow. Ouch.
Exactly. All right. Well, any other questions that you might have about diarrhea, Dixon, that we should touch on?
There are, I think we've already done it, but let's summarize. You've got chronic diarrhea and you've got episodic diarrhea.
And we've got our non-bloody and bloody
Non-bloody
diarrhea.
and bloody. So you can, as a triage officer, if you were aware of these and you could distinguish them, it would be easy to direct these patients to the proper clinic for further treatment.
And sometimes it helps the clinicians when they come through, when the vital signs, when they're being triaged, if you can ask what are helpful questions. You've got diarrhea. You might want to get a quantity. How much diarrhea? Is this a
Exactly.
3 small, or
Yep.
is this you had 1 loose stool, or is this you've been having so much? The issue, are you able to take stuff by mouth? That may help get a sense. Have you urinated in the last several hours? That's going to help us with hydration status.
Sure.
And then once they get to the clinicians, those decisions can be made for management. So.
Exactly. Very helpful. Very helpful.
All right. Well, thank you, everyone, for joining us again today.
We'll be back.
And we'll be back.